Hello, and welcome to the CAP Today webinar for Wednesday, March 19th. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host, and I'll moderate a Q&A session along with one of our presenters, Melanie Pollan from Siemens Healthineers, after our formal presentation. Today's webinar is entitled Prognostic Risk in Cardiac Patients using the Atellica IM High-Sensitivity Troponin I assay. Everyone on this call, I'm sure, knows that this is a very critical area of great interest to all laboratorians, many specialists, and of course, patients. I'm very glad to acknowledge Siemens Healthineers, who have made this webinar possible through their special educational grant. We not only wish to acknowledge Siemens Healthineers, but I want to thank them myself for helping to support this very critical program today. You'll enjoy three distinguished speakers. As I mentioned, we have a session that's been recorded for concision and time, and that will be moderated by my friend, Dr. Melanie Pollan, who's with Siemens Healthineers in medical affairs. She has great expertise, and she'll be joined by two very renowned, well-known experts in the field, Dr. Alan Wu, San Francisco General Hospital, who needs no introduction to a group that's assembled here, and Dr. Christopher DeFilippi. And Dr. DeFilippi is at Inova Health in Northern Virginia. As you all know, he also is a renowned expert in cardiology, and he has appointments there in their research laboratories and their heart and health center at Inova. We're going to cue the recording in just a moment, but I wanted to just give you a couple of tips before we begin. You'll use the Q&A pod that you see on your screen if you encounter any technical problems. And we have live people ready to help you should you have any of those type problems. Of course, the Q&A pod is principally there to allow you as a participant to ask your questions or make your comments. You can do so throughout today's session and with all the speakers. After we get through with this recorded presentation, we'll all come on live and answer your questions and comments. In about a week, we'll aim to post this webinar online at captodayonline.com. You should know that you can expect some follow-up emails from us and from our sponsor, Siemens Healthineers. So be aware, and we appreciate your help when we ask you for some help. Finally, before we begin, I want to remind you that CAP Today does not endorse any product or service that may be mentioned today. Any comments of mine are purely personal and not to be taken as policy of CAP Today or the College of American Pathologists. And with that, now I'm going to ask that we queue up the recorded session, sit back and enjoy it, and then we'll all rejoin you for questions and answers. Thank you very much.
Thanks, Bob. This year, millions of Americans will present to their local emergency departments with signs and symptoms of ACS. Their provider will most likely use a troponin test to aid in the diagnosis of acute myocardial infarction. Now, about 10% of these patients will actually be diagnosed with AMI, but what about the other 90%? 9 in 10 patients present to the emergency department with chest pain are not diagnosed with AMI. However, discharge for these patients does not necessarily mean they are cleared from experiencing a future major cardiac event. In fact, 39.5%, almost 40% of patients not diagnosed with AMI who present to the emergency department with an elevated troponin are at risk of a major adverse cardiovascular event or even death within a year. It simply means they're not having an active cardiac event right now. This past year, the Siemens Atellica High-Sensitivity Troponin I assay was granted the first of its kind claim for any U.S. troponin assay for prognostic risk for patients who are not having an MI. You can see in the second paragraph below that this assay can be used as an aid in prognosis for 1 month, 3 months, 6 months, or 1 year for all-cause mortality and major adverse cardiac events in patients presenting with signs and symptoms suggestive of ACS. And then it has the definition of MACE there as well, including myocardial infarction, urgent revascularization, cardiac death, or heart failure and hospitalization. Thank you for joining us today. In our time together, we're going to talk about the clinical significance of high-sensitivity troponin testing to support both acute and long-term cardiac care of patients. We'll talk about some real-life examples with nuances for clinical outcomes based on patient history, risk factors, and the clinical diagnostic protocol at their local institution. We'll also talk about this new prognostic claim, along with supporting data for different patient populations and how prognosis can be utilized in healthcare systems. We'll learn from both a clinician and a laboratorian perspective in the importance of coordinated long-term cardiac care management for patients presenting to the ED with suspected AMI. And then we'll take your questions and we'll talk about these questions with our distinguished presenters. So I'm going to hand the microphone over to Dr. Alan Wu.
Oh, thank you, Melanie, and it's nice to see you again. I'd like to thank Bob and the college for hosting this site and Siemens Healthineers for sponsorship. So this is sort of a tag team presentation. I'm the analytical side. We're going to talk about assay performance and why we should be interested in high sensitivity troponin. And then my esteemed colleague will talk about the clinical aspects. Next. These are my disclosures. Next. So as Melanie indicated, diagnosis of AMI is not as simple as it seems. The number of cases is only 10%. And so most of the time you're ruling out. And that puts a lot of stress on assays that have high sensitivity because you don't want to miss anybody. And no laboratory test is perfect. We can have false positives as well as false negative test results due to various interference like biotin, macro troponin, and all of these have been addressed in the Atellica Siemens IM assay to be immune, but we can never be 100% certain about any potential interference in a rare case. Next. So hopefully most of you on this call will not be unfamiliar with troponin. It is a protein that is found in a complex form with C, T, and I. It's released into blood when there is myocardial injury or irreversible damage. And the amount of damage is proportional to the degree of injury, although these days we don't really measure infarct size. We're really more interested in diagnosis and risk stratification. Next slide. Troponin has undergone an evolution of analytic performance in the course of the 30 plus years that it has been in existence. The first generation assay was woefully insensitive and was really not much better than our previous standby CKMB. Many of you out there listening are still using the second generation troponin assays. I have to say that if you're doing that, you are providing substandard performance, because today everybody needs to be on a high sensitivity troponin assay. This is the reason here. We can now measure troponin reliably in healthy individuals, which was not possible with the two previous generation assays. And then you can see here that acute coronary syndromes is characterized by a continuum release of protein. It is not just positive or negative. It's first signified by ischemia and micronecrosis with the onset of plaque rupture or demand ischemia. And then that's followed by a more significant release of troponin. Next slide. So the International Federation of Clinical Chemistry has a task force on the clinical applications of cardiac biomarkers, and they have regularly published guidance. I was a part of this task force years ago, and they have decided that high sensitivity refers to an assay's performance such that the 99th percentile has a coefficient of variance of less than 10%. That measurable troponins have to exceed that are less than the 99th percentile, but must exceed the limit of detection for the assay for at least 50% of healthy individuals. Now, in particular, we know, as I will show, that men have slightly higher levels of troponin than women, and it is a challenge for some so-called high sensitivity assays to measure healthy individuals amongst women in particular with at least 50%. Next slide. So this is a study that I participated in years ago. We created a reference bank for participants attending the AACC annual meeting in Atlanta a few years back, now called ADLM, of course. And from this sample bank, you can see here that the various high-sensitivity troponin assays have different degrees of sensitivity for healthy subjects, the subjects who attended that AACC convention, of which some of this information is my blood. And if you look at the Atellica Siemens product, 59% are detectable in women with an overall combined sensitivity of 71% of healthy. The other assays, including the troponin T assay, fall short of that 50% mark. Next slide. So high sensitivity attributes. The new thing on the block today is prognostic risk. We now have on the Atellica IM assay FDA clearance to use this high sensitivity troponin assay to determine the risk for major adverse cardiac events, as Melanie indicated, at 1, 3, 6, and 12 months after an indicating event. The assay, as I showed you in the previous slide, highly precise, 10-minute turnaround time, which is as fast as any central laboratory assay for high sensitivity, and minimal impact from common interference. Next slide. Here is the sex-specific cutoffs in the IFU for the Atellica IM assay. The limit of quantitation is listed here at 2.5. The analytic sensitivity is quite low, or I should say high, low limit of detection. The 99th percentile for women is at 34.11. You can see quite a large gap between the LOD and LOQ versus the cutoff. And then for men, it's up to 53. And some labs have chosen to use a combined cutoff that's really user-defined. And for the Atellica assay, it is 45. Next slide. So here is the first assay to include a prognostic claim. The Atellica high-sensitivity assay for in vitro diagnostic can be used as an aid in the diagnosis of myocardial infarction. That's not new. We've been using this assay in that regard on label, but now we can use this as an aid for prognosis to detect major adverse cardiac events defined as urgent revascularization, heart failure, hospitalization, and cardiac death. Next slide. So I want to walk you through some information that is present in the information for use. There was a study that was conducted, soon to be published. It included some 1,800 patients. And these patients were divided into 3 subpopulations. Well, the first population is the entire subjects, including those with everybody in the study, excluding those with adjudicated AMI, because we already know that if you are suffering from an acute myocardial infarction, you are going to be at high risk for subsequent major adverse cardiac events. That's not new. What is more important is to be able to determine risk stratification in the people who present with chest pain in an emergency department who have been ruled out. And so population 1, that's the rule out, everybody but the rule-in group. Population 2 is the subjects excluding both the adjudicated AMI diagnosis as well as any prior history of major adverse cardiac events, history or incident prior to MACE. And then population 3 are those excluding AMI, but including those with the history of MACE and prior events. So population 2 does not include the history, and population 3 does. Again, 30, 90, 182, and 365-day outcomes adjudicated by at least 2 cardiologists. Let's look at the results. Next slide, please. So this is population 1 at the 4 different time periods. And the key here is the separation between the groups in green, baseline values of troponin less than the 99th percentile, versus those in the orange, where the baseline levels were greater than the 99th percentile. And in every time interval, the individuals who show up with values greater than the 99th percentile had significantly higher rates of major adverse cardiac events, up to as much as 39.5% at 365 days, as Dr. Pollan mentioned. So that's population number 1, the entire group excluding AMI. Next slide. Now let's look at population 2, and what you'll see here is that the numbers are quite a bit lower. It's not 39% at 1 year, it's 15%. So that's the good news. If you've not had a history of prior myocardial events, and you're not suffering an acute myocardial infarction, your risk for developing adverse events is lower, but it is not 0. And in fact, there is separation between people who have a normal less than 99th percentile baseline level at 4.4% at 1 year versus those that have an elevated troponin. Now, these, again, not people with heart attacks. These are people that are at risk, even though they didn't have any previous history of any cardiac events. So for the first time, we have FDA clearance to identify these individuals and to hopefully mitigate their risks moving forward. We already know how to mitigate risks for patients with AMI. Now we can do the same with patients who have no history of AMI and no history of any prior cardiac event. Next slide. Okay, so here is the population 3 that excludes AMI, but it includes those with a history of incident or prior major adverse cardiac events. And now we are really jumping up in terms of adverse cardiac risk. We're talking at 50%, not 40%. These are people that really are going to have trouble if we don't intervene. And so this test allows us to determine who's going to be at the greatest risk. Next slide. So these are the takeaways here. the three different populations all on a single slide, that we can reduce healthcare burden associated with repeat emergency department visits in patients who present with cardiovascular disease. Next slide. So it is my pleasure to introduce my friend and colleague, who is Vice Chair of Academic Affairs at Innova Health and Vascular Center Institute in Virginia, Christopher DeFilippi. Chris?
Thank you, Alan, for that kind introduction. You're going to be a really tough act to follow. First, I'd like to thank Bob McGonigal and Cap for putting this together, and Stevens for inviting me to participate. I've been interested for much of my career in prognosis in individuals who are not having acute coronary syndrome. So the fact that this FDA claim is now available, I think is going to do a lot to the field. Next slide, please. These are my disclosures. And next slide. So over the next 10 or 12 minutes, I have the following three learning objectives with all of you. First is to assess the epidemiology of coronary heart disease and other cardiovascular disease and their potential influence on cardiac troponin levels in the absence of an acute coronary syndrome or acute myocardial infarction. And two is to review the contemporary cardiovascular guidelines for the evaluation of patients presenting to the evaluation of acute myocardial infarction, taking the angle of the American College of Cardiology and the American Heart Association and their recently published guidelines. And lastly is to evaluate data supporting the new prognostic indications to the Atellica IM high-sensitive troponin I assay in patients presenting with chest pain or equivalent, with or without an acute myocardial infarction. Next slide, please. When we often think of cardiovascular disease, we think of coronary artery disease. And of course, this is a prevalent form of cardiovascular disease, but we shouldn't forget about numerous other etiologies for cardiovascular disease that often can result in elevations or chronic elevations due to chronic myocardial injury of circulating troponin levels. And this includes heart failure. That's the heart inability to pump blood effectively, often resulting from long-standing coronary artery disease or hypertension, prior myocardial infarctions. Arrhythmias, irregular heartbeats, the most common that particularly becomes quite prevalent with age is atrial fibrillation, and in the figure to the lower right, you can see two ECGs, a normal one and an atrial fibrillation with the associated irregular beats, which can affect performance of the heart, and particularly high heart rates can lead to release of cardiac troponin. Valvular heart disease, which is damage or defects to one of the heart's valves, the aortic valve or the mitral valve. Cardiomyopathies, even in the absence of heart failure. These are diseases of the heart muscle that may lead to heart failure, arrhythmias, or sudden death. And then lastly, congenital heart disease. We're seeing, because of the success of treating children with congenital heart disease, a larger and larger population of adults who now lead normal or fairly normal lives in terms of function, who have a diagnosis with congenital heart disease that's been corrected at a young age. Next slide, please. So a little bit about the epidemiology of cardiovascular disease overall. So every year, the American Heart Association presents updated statistics, and though they typically are taken from several years prior. And this was from a publication this year that looks at cardiovascular disease as divided across generations of age, males and females, and the presence or absence of hypertension. So if we look at the turquoise and blue bars, which represent males and females who do not have hypertension, what is the burden of cardiovascular disease? And you can see, particularly by the time individuals reach the age of 60 or more, it actually becomes quite prevalent, affecting, like in older ages, approximately a third of the population. And next slide, please. Now let's focus back to coronary heart disease or coronary artery disease, and recognize the prevalence of this in the population, because going back to Dr. Wu's talk, recognizing that even individuals who don't have a history of prior known cardiovascular event with an elevated troponin are at higher risk for coronary heart disease type event. And you can see once again, particularly as the population is aging over the age of 60, that in men and in women, the prevalence of coronary heart disease is quite high. Next slide, please. And depending on which region of the country you live, the prevalence of coronary heart disease can be quite variable. So from our first speaker, who did all her training in Mississippi, the prevalence of cardiovascular disease is quite high. But, with a few exceptions in the country, if you look at the age-adjusted prevalence, cardiovascular disease, coronary heart disease, is highly prevalent throughout most of the states. Next slide, please. So this epidemiologic information was to put in context the findings that Dr. Wu discussed, and that I'm going to refer to as we talk about how we in contemporary medicine evaluate patients who present to the chest pain, or present to the emergency department, for the evaluation of chest pain. So this is the mnemonic that has been developed by the American College of Cardiology and American Heart Association, chest pain. So we'll refer to a few features of this mnemonic. So first, chest pain means more than pain in the chest. Presentations can be very atypical for people who are having a myocardial infarction, and thus the fact that virtually anyone who may have a symptom that could be referable to a myocardial infarction ends up undergoing a full workup. Next slide, please. So how often, to put this in context, do in fact people who come with chest pain have a myocardial infarction? You heard this referred to earlier, it's about 1 in 10. You can see that for the most part, the final diagnosis, whether you're middle age or older age, is still greater than 50% of the time. The chest pain is ascribed to be non-specific. In other words, you don't really know why it's happening. Coronary atherosclerosis is the next most common etiology. And of course, as one gets older and more frequently, the chest pain is more frequently referred to, coronary atherosclerosis. You can also look at in older individuals, the other diagnoses that occur that are thought to have caused the chest pain are becoming more cardiac specific. Cardiac dysrhythmia, atrial fibrillation, for example, congestive heart failure, as well as, of course, the myocardial infarction. Next slide, please. So let's take a look or review a few of the other parts of this mnemonic. As Dr. Wu had referred to earlier, and it is certainly well supported by evidence and recommendations through the American College of Cardiology, American Heart Association. The recommendation is now to use a high-sensitive troponin assay. We'll talk a little bit more why implementing that as part of a chest pain algorithm can be helpful. In addition to using a high-sensitive troponin algorithm, if you move over to the right and look at the next key pathways, the clinical decision pathways that incorporate signs and symptoms, the electrocardiogram as well as the troponin are what's recommended. It is important to recognize that women can often present with more atypical symptoms, and a high index of suspicion is important. Though they may not have as much, the prevalence of coronary atherosclerosis isn't as high as you saw. It is not trivial whatsoever. And that one of the things as part of the workup that we want to be able to do as emergency department physicians or cardiologists or as general internists who are caring for these patients is not only, of course, identify who's having that acute myocardial infarction, but as you've seen from the data that Dr. Wu presented, it's really important for us to identify those individuals who are at risk, who are going to need further cardiovascular workup, whether that workup should take place, such as a stress test, CT coronary angiography, traditional invasive coronary angiography, should take place in the hospital setting during that encounter, or in the near term. It can depend on the particular signs and symptoms for that patient. And next slide, please. So this is the algorithm that's recommended. There are a lot of different directions you could go, but if you simply sort of follow the old red ovals that I've created, this is where most individuals go who end up getting the troponin measured. So someone presents with acute chest pain. There's some uncertainty that this could be an acute coronary syndrome. They'll typically have an electrocardiogram. The electrocardiogram is often normal. Now, if it shows these ST segment elevations, really we're out of the algorithm. The importance of the immediate troponin is not important in these patients. Now, under present guidelines, they'll immediately do a cardiac cath lab for urgent revascularization. This is a small minority. This is 1 or 2% of all the cases of people who show up with chest pain. So many individuals have either a normal ECG or some non-specific abnormalities that have what we call possible acute coronary syndromes. And this is where we deploy a troponin assay, ideally the high-sensitive assay, and we also deploy these clinical decision pathways. And let me just describe one to you. There are a number of them out there, and different emergency departments may have created their own as well. But this is just a nice mnemonic to incorporate history, ECG, and troponin measurements. A popular one that's used throughout the United States is called the HEART score, and H stands for the history, the chest pain. E stands for the electrocardiogram. A is age for older adults. These all are point assigning parts of the mnemonic. Older age will assign more points because there's more risk. R is for risk factors, those traditional risk factors like smoking, hypertension, and hyperlipidemia. And of course, T is for troponin, an elevated value greater than the 99th percentile. The general population also identifies individuals at higher risk. Risk is then assigned to people lower, intermediate, or high risk. There are a number of algorithms that are out there now that can measure troponins at sequences as frequently as 1 hour apart. 0 and 2 hours are commonly adapted as well. Next slide, please. So lastly, I want to circle back to prognosis. And this is creating novel information from the traditional indications. And so we're going to talk about prognosis briefly in acute myocardial infarction patients and then other chest pain patients to put the findings from the Atellica IMHigh-Sensitivity Troponin I assay in context to what is known out there in the literature. Next slide, please. Yeah, well, this is old data. I think actually this may be when I first met Dr. Wu. Around the time this paper was published, both of us being quite interested in troponins fairly early in my career. This is almost 30 years old. This is a New England Journal of Medicine paper, and it simply said using the first generation assay that in patients who are having acute coronary syndromes, in fact, myocardial infarctions, that the higher that troponin was on presentation, the poorer the prognosis. And you see that in the lower left in terms of 42-day mortality. These patients presented with acute coronary syndromes, which you see in the lower right, is a multivariate analysis that even once you adjust for traditional risk factors, the electrocardiogram, the troponin remains an independent predictor of items. So prognosis in the acute coronary syndrome, acute MI setting, that's been known for a really long time. Next slide, please. In fact, we've had a pretty good understanding of people who come to the emergency department with chest pain who do not have a myocardial infarction, they do, in fact, have a poor prognosis. What Sting has gone ahead and done by obtaining this FDA claim is they've rigorously evaluated the information from their own study. But this is an example from 5.5 years ago of a registry study published from Sweden. Why Sweden? They do a very good job being a relatively small study and having a very centralized health system of having a long-term prognostic information that's electronically codified. So what you're seeing here are individuals who had values who came to the emergency department throughout the country and were followed up for as long as 10 years. They had values below the 99th percentile for whatever assay that particular hospital was using. And then you see progressively higher levels above the 99th percentile represented by tertile. So what you see in the Kaplan-Meier survival curve on the left is the blue line represents those with values below the 99th percentile, and the orange, gray, and then red lines represent progressively higher values. The individuals who, again, were presented to the emergency department with chest pain, but did not have a diagnosis of myocardial infarction, very similar to population 1 that Dr. Wu was speaking of. What we see on the right, on this box and whiskers plot, are a number, again, of subdivisions of different populations. So if you look at the total population, you have progressively higher values above the 99th percentile, indicating a poor prognosis with respect to a major adverse cardiovascular event over 10 years. And as you further refine that population, as you see with subcohort 1, subcohort 2, and subcohort 3, to exclude patients who either had a prior history of cardiovascular disease, people who were particularly at risk, such as those with chronic kidney disease, and then even excluding people who may have a no coronary stenosis or lower ejection fraction without a prior cardiovascular event, the risk still all remains. And Siemens, by including now this prognostic claims, is going to raise awareness for their troponin assay and frankly probably all troponin assays that individuals who are not having myocardial infarction but have an elevation of troponin above the 99th percentile presenting to the emergency department are in fact hybrids for major adverse cardiovascular. Next slide, please. So with that, I want to thank you for your attention to my talk, to my colleagues, and I'm going to return this to Bob McConnell.
I want to thank our speakers for what has been a magnificent presentation on high sensitivity troponin I in cardiac patients, and particularly wonderful emphasis on both the science and now the FDA-approved claim for prognostic risk, which I think is going to be increasingly important in our systems. I'm sure you'll agree with me, this has been very rich. Let me remind you, you can go to the Q&A pod on your screen as an audience member and make a comment or ask your questions. We'll give you a second or two to go ahead and do that as we catch our breath. But first, I'd like to thank my colleague, Melanie Pollan. I'll call you a colleague since we're both doing some moderating today. And I know that you had a question or two that you were curious about. So why don't you lead off with a question for our distinguished speakers?
Yes, sure. So I was wondering if you guys could speak to the real-world implications for health systems who are using the Siemens Atellica high-sensitivity troponin I assay, the one that has this claim.
Yeah, and from the analytical side, and then I'll pass it on to Chris. In the laboratory, we provide data and results and don't really make interpretations in terms of risk stratification. But it is our responsibility, I think, to educate both our providers and as well as the other medical staff as to the availability of this test and the fact that it is cleared for risk stratification use. But then how do we mitigate that use? This is where we have our clinical experts that really need to jump on board.
Yeah, I'll follow up with that. Alan is a clinician. So I work for a moderate size health system. I guess virtually all physicians work for health systems now. I work at the larger hospital where we have residents and we have fellows in cardiology. So there's a pretty high level of awareness. I think that for tertiary or even these quaternary hospitals, there's probably a reasonable awareness level already, though defining it more carefully is important. But what I do see, we're part of a large network. We have about 5 additional hospitals spread throughout the region of Northern Virginia, and sort of the penetrance of how much someone follows the troponin literature, even as a cardiologist or an ED physician, can be quite variable. So the ability as another method to be able to get that information out there beyond what's published in the literature, I think is going to be really impactful. So I think it depends on where you're practicing, but for many hospitals, I think this is going to be new information, or at least reinforcing information and awareness that people who do present without a myocardial infarction, but they've got a value above the 99th percentile. You haven't seen that before. It's not in the medical record, that many of these patients, as the data that you showed, Alan, really warrants an evaluation. It doesn't have to be an evaluation that day. They don't necessarily have to remain in the hospital, but they do need follow-up over the next couple of weeks and probably additional diagnostic testing with imaging.
Thank you, Doctor. We do have some very technical laboratory questions, as you might expect. But before I turn to Dr. Wu to help us answer those, I'm just curious from your perspective, and you did show we've seen some very interesting geographical breakouts, which are suggestive of populations and of habits. We all know that obesity, smoking, inactivity, the list goes on and on, are of themselves risk factors, and I'm sure you've counseled patients since you were a resident on those sorts of issues. But just tell me, I'm curious, now that there's an actual predictive claim, do you feel that in the right counseling hands, that you really begin to change some patient behavior? In other words, when someone says you have a very high risk of having a heart attack now.
Yeah, absolutely. So, with respect to that demographics map that I showed, that was around coronary heart disease. But, you could change that map and you could look at cardiomyopathies and heart failure. And that may change in terms of where you see that high prevalence of that. So we could take an individual who doesn't have a myocardial infarction, but really has a history that could be consistent with some significant structural heart disease. What do I mean by that? Left ventricular hypertrophy, maybe beginning evidence of heart failure in terms of decreased pumping function of the heart, perhaps some early valvular heart disease, an older adult who has moderate aortic stenosis. And we know in all those cases in the published literature, now we're, aggregating it in terms of this claim for people who present, that their prognosis is worse. And so that early identification can lead to some very simple interventions, like better control of hypertension, maybe further evaluation of valvular heart disease, better rate control for someone who has atrial fibrillation. So it definitely can make a difference. And picking up a few people who have ischemic heart disease too.
Very good. Thank you very much. So the significance of this is not to be underestimated. Dr. Wu, as I mentioned, we've got some questions, as we would have expected from the lab folks in many cases. Let me start you off with a friend of mine who is actually a microbiologist, which may explain his question, but I'll let you expound on that. what information do you suggest, or what history do you have regarding the use of a delta value with this assay? And I do know that there are some more explicit things we can say about delta values in this context. So I'll invite you to do that, Dr. Wu.
Yeah, so delta values are important for ruling in and ruling out AMI, and there are published results that have documented a delta level. However, the Atellica assay and the FDA approval for diagnosis does not post a specific delta. This is really sort of a user-defined, something that you would encode in your algorithm for rapid rule out. Now, in terms of risk stratification, delta changes are not as important because the key here, as in the slides that I showed, is whether or not a single value is elevated above the 99th percentile or not. And there is no really additional information gained by a delta value. Perhaps Chris can opine on whether or not that is accurate.
No, Alan, I completely agree. You know, some of the examples I gave about hypertensive heart disease, valvular heart disease, other forms of cardiomyopathies are all chronic. You look at the fourth universal definition of MI, they're going to come in as chronic myocardial injury. Usually that's defined as elevation defined, in this case, above the 99th percentile, whether you're using the sex-specific or the non-sex-specific cutoff, and you generally don't see much change. In fact, the algorithms in the ED, these 0, 1, 0, 2 algorithms that have been widely adopted, often, you know, they base themselves on a level, but very frequently they also base themselves on the rapid change. So this prognostic claim is not related to change, but just to the elevation above the 99th percentile with the exclusion of a myocardial infarction.
Very good. Thank you. Dr. Wu, we have, as often is the case, we want to be sure we know the nature of the specimen we're going to be analyzing. So if you could comment briefly, is it true the analyzed specimen is plasma? And if that's the case, what do you use in your practice as the anticoagulant?
Well, either serum or heparinized plasma can be used. EDTA, I believe, cannot be used, and I might stand corrected with Dr. Pollan, but it is our practice to use lithium heparin because it doesn't require the sample to clot, and we can spin it immediately after receipt. But serum can also be used and is widely used.
Very good. Thank you. Dr. Pollan, would you like to make a remark since we brought you into the discussion?
I was just going to say that for the Siemens assay, you can use either serum or heparinized plasma. The important thing to remember is to use the same one throughout your serial collection protocol. So like Dr. Wu said, some facilities prefer just to standardize on one, and that way you don't have to worry about mixing up the specimens.
Thank you. Dr. DeFilippi, we have a very good question, and I think a very important one, so let's dwell on this for a minute, if you'll indulge me. How would you involve your clinical colleagues in the ED to use this new high-sensitivity troponin assay for risk stratification, given that, as we all know in an ED, the immediate focus is on diagnosis and not necessarily prognosis? Is there a threshold value or possible range above the 99th percentile that could help there?
Yeah, actually, I'll take a step back about 2 years when we adopted a high-sensitive troponin I assay throughout our system, you know, just evolving to the next generation of instruments. And we put together a working group that had the laboratorians, had the cardiologists, and had the ED physicians. And we went through what type of accelerated diagnostic protocol that we were going to want to take. We ended up doing 0 and 2 because based on the lab's feedback, that was sort of a reasonable turnaround time that we could expect. Within that, we said, all right, how are we going to manage, the trepidation was there are going to be all these elevated values and we don't know what to do with them. So that was part of that conversation when we made our initial transition to the high sensitive. Certainly there wasn't yet an FDA indication for the assays, but there was a lot of knowledge in the literature. One example, which I showed during my presentation. So we already have built in, people who fall into this group, sort of at the judgment of the ED physician, in most cases can be referred to cardiology as an outpatient. We have actually a setup to do that and get people in within a week. If they think there's more acuity behind it, then an admission and an inpatient consultation with cardiology as well as an inpatient thing. So it got, well, I guess that's a long answer to say that when we did our conversion to the high sensitive troponin I, we knew we were going to be faced with a lot of elevated values, elevated being above the 99th percentile. So as a working group of the three specialties, we sort of put that in place.
Thank you. Thank you very much. And it's still being worked through, as we all know. Particularly, we need to do a feature story on this almost once a year. But with this new indication, it's enormously exciting for us. Dr. Wu, would you care to comment on this last question and answer? And perhaps give us a little bit of your experience in adopting the high sensitivity assay.
Yeah, so we followed the model that was done at the University of Texas Southwestern Medical Center in Dallas. A good friend of ours, for Chris and my friend, and somebody that we rely on heavily. And so we have a 0, 1, and 3 hour rule out protocol. The delta cutoffs would be a little bit different because the frequency of testing is a little bit faster. So this puts a tremendous stress on the lab to get a result of the baseline value within 1 hour. And the fact that the Atellica assay has a 10-minute turnaround time really does help us a lot, because some of the other assays from the central laboratory are 20 minutes, and it becomes really tight to get it done. So 0, 1, and 3. And James DeLemos for his assistance in helping us.
Yes, I think that's been widely adopted amongst the better experts, at least in my opinion. Dr. DeFilippi, would you care to comment on that same?
Yeah, so James is a good friend, and we do it slightly differently.
Okay.
Well, we did. So when we made our conversion, it was December of 2022, and that just and I saw a question in the but what algorithm do we use? So the American College of Cardiology, American Heart Association, I think the emergency department, emergency medicine society had come together, and they developed several algorithms, a 0-1, a 0-2. They talked about a 0-3, pros and cons in all of them. Because I guess we were the latest, greatest, from the cardiology societies / emergency medicine society, which came about a month and a half before we had our series of meetings to develop a protocol. We chose to adopt, as I mentioned, the 0-2, not the 0-1, because of the turnaround time that we thought our laboratory, or what our laboratory informed us we could do in the emergency department. Physicians were quite comfortable with the 0-2. Remember, we were going from like a 0-6 on the traditional assay, so this was still light speed in our mind, and so and we don't feel that we do additional testing if people fall, as they look at these algorithms, in what's called the intermediate zone, and about 25 to 30% of people will fall in the intermediate zone. That's often these people we're talking about who have this prognostic claim where they have an elevated value. It doesn't change very much over 2 hours. We will do an additional test between 3 and 6 hours with them, typically.
Thank you. I have a question now for Dr. Melanie Pollan, particularly stimulated by the observation as presented in the session of the difference between men and women when it comes to some of these values and testing values. So my question to you is fairly general, Dr. Pollan. Could you comment on the health equity that's embodied in this test and the value that this test will have to improve health equity?
I think probably the question would be better directed toward Dr. DeFilippi and Dr. Wu, right? I know that Dr. Wu noted in his slide that there's difference in performance with regards to the high sensitivity, like how they meet the definition for some of the different manufacturers. So, yeah, I think it would be great if one of them could comment on what this means for assay choice and whether or not it could have an impact on the patient population with regards to health equity and the diagnosis for women.
Dr. Wu, to start us with that.
There was a movie by Mel Gibson entitled Leave Nobody Behind. And it really refers to the fact that women have lower normal values. And then if we were to apply the male cutoff, that there would be some women who have values between their cutoff and therefore would be labeled as positive, and the men's cutoff, which would have been labeled as negative. Now, it probably doesn't happen very often. We know that the levels are going to change quickly, but we don't want to leave anybody behind, and especially if it's at an early stage where you're taking advantage of the differentiation between sex-specific cutoffs. If you have these values and they're firm, then our recommendation is to use them for that reason.
Thank you. Dr. DeFilippi, a quick comment on Dr. Wu's reply.
Yeah, I'm in agreement there. Nick Mills from Edinburgh, Scotland, was the first, as I recall, to really look at the specific 99th percentiles for the diagnosis of myocardial infarction, and did show an additional several percent women who would be diagnosed with a myocardial infarction. I think the same can apply to the 99th percentile in prognosis. I mean, there's really, I think, we know that actually there can be structural heart disease or ischemic heart disease well below the 99th percentile. There have been lots of studies in the general population cohorts that say, pretty much there's a gradation starting from the level of detection on up and going past the 99th percentile that says you have increased risk. So the claim is based on the 99th percentile. There's probably risk below the 99th percentile. So I really err on the side of using the sex-specific 99th percentile cutoffs, because for women, it's going to be a lower value. It just means there's going to be more detection of structural heart disease, more recognition overall of cardiovascular disease, opportunities to start a chronic intervention, even if it's just the treatment, a more aggressive treatment of hypertension.
Thank you. Thank you for that comment. For our last question, I want to get a little futuristic, so I hope you won't mind that. But I can't help but think now with a prognostic risk claim, as I think about this for the future and realizing that healthcare is not exactly awash in funding and dollars, no matter where you are these days, and that cardiac care is expensive care in emergency rooms and procedures and medications and lots of visits to the clinic. So go ahead and blue sky for me a little bit, if you both would, about the future savings, the brighter future that really having good prognostic risk and an understanding of that and communicating that to patients might allow us. I'll ask you first, Dr. Wu, and then I'll ask Dr. DeFilippi to give us the last word on that. Dr. Wu.
Yeah, so cardiac disease, I think now is number 2 in the most common cause of death in the Western countries. It used to be number 1. Cancer, I think, has somewhat surpassed it. And that's a testament for groups like the American Heart Association, American College. But I think that the clinical laboratory community and the IVD industry also has a role by developing new biomarkers and improving on the existing ones. We mentioned briefly about CK&B. Thank God that we've gone past that. We're doing so much more now. And this is all led, along with interventions by great physicians like Dr. DeFilippi, that have in fact, made a difference. And so definitely this is a teamwork effort, but more needs to be done.
Very good. Dr. DeFilippi, particularly the same question with a thought to how this may be of enormous benefit to, not only to patients, which is obvious, but to the economics of cardiac practice.
Yeah, I mentioned I started my career in the late 1990s. And part of it was my interest in research was what I saw even with the early generation troponin assays at that time, in which, CKMB would rule out a patient, and for some reason they underwent further diagnostic testing and they had multivessel disease. With the more refined, more sensitive versions of high sensitive troponin, we're really into the realm of being able to detect things that are more subtle than multivessel coronary disease. I think it's important to recognize that it is able to detect disease that may not be easily detectable by other standard methods like a stress test with nuclear imaging or a CT coronary angiogram. And therefore, I think there needs to be a judicious thought process or use of what's the next step. With my colleague, James DeLamos, who we mentioned from UT Southwestern, we look, for example, very simply combining an elevated troponin above the 99th percentile with ECG evidence of left ventricular hypertrophy. So real evidence of structural heart disease with a very inexpensive, ubiquitous test. These patients have a particularly poor prognosis with respect to developing heart failure or dying of cardiovascular disease. So maybe there needs to be a little more refinement in terms of simply implementing a test like the electrocardiogram, which of course would happen in the emergency department. But I think that it will provide the opportunity for many individuals to get identified and treated in still what we call the primary prevention phase of their disease before they've developed symptoms, improve quality of life, and hopefully, ideally, reduce medical costs, as long as we don't have a knee-jerk response that says, I need to do some expensive imaging tests because I've got an elevated troponin, and then get disappointed when it's normal.
Okay, thank you very much. I'm going to turn to Dr. Pollan now to give us a summation. And when she's finished, I will make my final acknowledgments and close this up. But Dr. Pollan, you have the last word.
No, I was just going to say for aspirations about troponin, who knows where we're going to go, but I think I'm most excited about this new claim because I think, like I said in the very beginning, it gives us the opportunity to use this test for the 90% of people who are getting it that did not have a heart attack. And so I think that sets maybe a good direction for the future, for the utility of the assay and the treatment of the patients, right? That's the end game, is to make sure that we're giving good patient care, really awesome patient care, right? So thanks for your time today.
Thank you very much. I want to note that many of us who are lifers in the IVD and laboratory world, we often note we're about 2% of the expense, but we're affecting about 98% of the overall healthcare expense when we use our tools, as well as we're talking about today with the Siemens assay. And so with that, let me go ahead and wrap up. I want to thank, obviously, our speakers, Dr. Melanie Pollan of Siemens Healthineers, Dr. Christopher DeFilippi of Inova, and of course, Dr. Alan Wu, San Francisco General. I want to thank, of course, Siemens Healthineers. Their sponsorship has made this program possible, and I hope you've enjoyed it. It will be posted for your review and sharing with colleagues. We're very excited about that. And finally, let me thank all of you. We know things are busy. There's lots of shorthandedness everywhere I go in laboratories. And I really appreciate you taking time to join us today for this wonderful session. So thanks to all of our speakers, thanks to Siemens, and thanks to all of you. And with that, I'll bring today's webinar to a close.